So at this point, we're ready to start our first session on examining marriages and family. This session is going to be chaired by Theresa Osypuk. Theresa is professor in the University of Minnesota's School of Public Health in the Epidemiology and Community Health Division. Her research examines how place and other social exposures influence health and health disparities. Theresa is the director of our NACHD-funded Minnesota Population Center and is co-director of the training program in population health sciences. So Theresa, I'll let you go ahead and kick off the session.
So much. It's a pleasure to be here. I am going to get us started examining marriage and families. Our first speaker is Gilbert Esteve. He is the director for demographic studies in Barcelona and full professor in the Department of Sociology of the Universidad Autónoma de Barcelona. He's stretching my Spanish here. He's a family social demographer specializing in family change and general demography. And he's also the rector of the European Doctoral School of Demography. We're going to have 15 minutes. I'm going to give him and all the speakers cards that their time is up. And please welcome him.
Good morning, everybody. Thank you very much for inviting me to this party. My name is Gilbert Esteve, and I'm a social family demographer. And in recent years, I'm trying to understand why families change and under which conditions we see these changes. And I would like the main idea of my presentation is basically that thanks to IPUMS now, we have the dream of studying global family change is closer. But before developing this idea, I would like to, I brought you a cake. This is a very healthy one because cannot be eaten. And I would like to congratulate all of you for this extraordinary achievements that you have made over these first 3 decades of life. But I'm biased in this IPUMS business, and I found a reason to celebrate another anniversary, which is for IPUMS International 25 years. I know that I was checking with Matt Sobek whether I could find a reason to celebrate 25 years of IPUMS International, and then he told me that perhaps the project was conceived 25 years ago, and depending on how you measure life, it could also count as 25 years of IPUMS International. No? But maybe you might be wondering why I'm today opening this session, and I have to tell you that I spent wonderful years of my life back in year 2000. I spent almost 3 years in Minnesota. I met very good friends, and I learned a lot, and it changed completely my academic life. And I have had very successful projects in Europe, mainly using IPUMS microdata. So I owe you a lot, but there's other reasons. I'm a big IPUMS user. I'm a former IPUMS employee, but I'm also probably the largest non-US collector of IPUMS Macs. And yesterday they gave me another one. So probably I challenge you, if anybody of this room has more Macs than I am, because I was so lucky traveling all over the world with Professor Robert McKay, and we were giving Macs to all heads of the national statistical offices. But at the end of the day, there were some left, and nobody wanted to give me back. So I was keeping all for me. So I have more than one copy of each of these Macs. Okay, so if you want to update your collection, I'm happy to change them. But what I'm celebrating today is the extraordinary achievements of IPUMS International, or let me say it differently, the international branch of IPUMS International. Of IPUMS, I'm sorry, because you know that 30 years ago, there was only one country for which IPUMS was providing data, that was the United States. But then IPUMS International arrived, and in year 2002, there was the first release of IPUMS International with 6 countries: Brazil, Kenya, Vietnam, France, Colombia, the United States, and Mexico. But today the map covers almost the entire world. No, like we have as of today 103 different samples from different countries. And this is I know that in the next weeks there will be 2, 3, 4 more countries added into this collection. But as you see, there are some gaps. But thanks to another international IPUMS project, was the Demographic Health Survey. Now IPUMS also offers access to 45 countries. And then last week, before this event, all of us received an email saying that you can access the IPUMS mix, the multiple indicator cluster surveys by UNICEF. So today we can go online and make a request data structured system of these 88 countries. As you might have seen, the coverage of IPUMS is quite impressive, but there are some areas of the world where still it's difficult. And one of them is Europe, because we have very old samples and they are not refreshed because Europeans are a weird population, and the Eurostat, they never want to reach an agreement with IPUMS International, but researchers, even from the United States, they can apply and they can get labor force survey microdata from Eurostat for free, and they send you the whole data set. But what I want to say is that together with IPUMS, censuses, DHS, mix, plus the possibility that we all have to get microdata from Eurostat, we could get some sort of a map like this, that today it is possible from our computers, from our offices, without spending a single euro, because others have spent it before, but we can get data for more than 150 countries. And this is a map that my team has created, where you can see whether there's countries for which we only have IPUMS microdata, only DHS, only LFS, only mix, or the greens. That means that for many regions we have, or for many countries, we have samples from different data sources. I have identified the countries for which we should create some IPUMS special mission or something like this, because it would be Japan, Norway, Saudi Arabia, Libya, and Iceland. These are, we know that they have data. No, in Libya, I think they don't have data, and Saudi Arabia, I don't know, but it's been almost impossible to get it. However, I managed to get the Australian data, because they also have a very easy application. It's a data set called Hilda, that you just send an email and fill some forms and you can get it. So it's possible for a researcher, together with IPUMS, plus the labor force surveys in Europe, plus Hilda in Australia, in 10 days, you can get all this beautiful map. And it's not only about temporal coverage, but spatial coverage, but also about temporal coverage. So here it's a summary, an inventory that we are doing in Barcelona of all the countries by big continental regions, the availability of samples over time, and the different dots identify if we have a sample for that year. And then the shape of the dot tell us whether it's from IPUMS, DHS, LFS, mix, whatever. And then the color of the dot tell us whether we can get subnational or not, and whether we can get subnational over time. And we can compare over time the data set. So thanks to IPUMS, we have a beautiful spatial coverage, also very nice temporal coverage, and also very nice subnational coverage. And this is the boundaries that we are working now. It's more than 3,000 units. And then with the data just show you, now researchers could study families, could study, household change, living arrangements at all these levels. So we can conclude that really IPUMS is a real utopia, and that the dream of conducting a global study of the family has been brought to life, so we can start working. Okay, but I would like to make a mention. So whose dream? So I don't know whether you dreamed last night about doing a family research at the global scale. Probably not many of us dream very often about this, but we know in history that there has been very great scholarship thinking about the family in a global perspective. So here, let me honor some of them. So the first one, it's Frederic Lipley, who he outlined some various family typologies and connect them with some different economic conditions. Almost 100 years later, the big book, William Booth's book, saying, the world is industrializing, there's a lot of change going on, and I expect that families will sooner or later converge to what they call the conjugal family household. But just few years later, there was a very famous scholar who thought differently and say, oh my goodness, I'm seeing that the English families are nuclear for many, many years, and perhaps they were already a very small families even before industrialization. We should pay more attention to the legacies and to the family systems and to the different kind of cultural dimensions that they are embedded in all these families, and try to avoid these kind of comments that families will turn to converge. In this line, we have the most recent, perhaps, book dealing about the wall, which is this Between Sex and Power, where he kind of defines which are the main family systems in the world. And he reaches this conclusion that family systems change, but they do not converge, because there are some legacies there that really that define some sort of the future evolution. And then we have also great scholar, probably the person who dreamed more about this idea of, it's Steve Ruggles, that he did all this beautiful work on examining long-term transformations in families and households, but always using empirical data. His international work, I've seen several papers, but he has not yet done what he has done for the United States, for the entire world. So I think that with this great scholarship and this great data, we can ask whether, thanks to IPUMS, are now closer to understanding family from a global perspective. And here I say I'm a little bit pessimistic, because my perception is that the more data we have, our sociological imagination goes down, and then we don't dare to write anything big because we're afraid about the data. Because many of these scholars were writing this where very few data, a little bit evidence there, but now we have hundreds and hundreds and hundreds of thousands of households that we can analyze, and then we realize that reality is more complex. So I'm trying to do this, but I'm trying to do this learning the lessons of the previous scholarship. And I think that if I ever dare to write something on a global level, there's some lessons that I've learned crunching my own numbers, and also listening and reading and learning from the scholarships, from the scholars that I just mentioned. First of all, I think we have to be aware that there's always this tendency and focus how things will change without paying attention what's kind of the starting condition. So I think a balanced theory should care about change, but also should understand very clear which were the different family systems, the different geographies where this change might take place. Another lesson is that sometimes when we do these macro level theories, we like to have some supranational logics, and we like to define big areas. This is like in Europe, Eastern Europe, Southern Europe, and we are repeating over and over because Josta Spin-Andersen made a typology, and then everybody uses that typology without necessarily testing whether this group was homogeneous or not. And we know that there's a lot of diversity, not only within regions, but also within countries and across countries within Europe. So at all levels, we have heterogeneity, as I'm showing in these maps. And then the other thing that for a global theory of family, we should not pay that much of attention to the individual variation sometimes, because our micro level research basically now, it's very much oriented in the same, why high educated people will do more this and that, or the effect of this on that. But when you see from a big perspective, you realize that many of these individual covariates, they have very little to do when we try to explain differences across country. So even controlling by a set of individual characteristics, you end up having very large regional effects. So context a little bit matters a lot. And then another thing that many of the theories, see people that have sociological backgrounds, they either go for structural explanations and they go for cultural, and they kind of fight, and they don't see that they can be somehow together, and sometimes they evolve simultaneously. So I think a theory should also take into account and not use these explanations as competing explanation, but more as in a collaborative approach. So with this idea in mind, we are now starting to produce evidence to write this kind of global understanding of the family, since I personally lack the sociological imagination that the scholars I cited had. I'm starting from a very empirical basis, and my team in Barcelona, we are documenting as many dimensions of family's life as possible. And this is the last maps that we have produced. This is, for instance, a very simple one, which is the average household size at the subnational level all over the world. And this is my last graph, this is the percentage of households headed by women also at the subnational level, for using the most recent data from all these databases that we are combining. And hopefully in 10 years, we will have more results to share with you. And this has been possible mainly thanks to IPUMS International. So thank you very much, and time is up. Well, thank you.
All right, it's my pleasure to introduce our next speaker, Joanne McLaughlin. Dr. McLaughlin is an associate professor at the University of Buffalo. She's a labor economist studying labor market issues with a particular focus on public policies such as discrimination, intersectionality, health insurance mandates, gig work, and AI, and the future of work. It's my pleasure to introduce Dr. McLaughlin.
Hi, I'm Joanne McLaughlin. Thanks for having me. I arrived yesterday. I'm having a wonderful time. And I'm excited to be here because I'm a big fan of IPUMS. And the other thing that I learned was that it's not IPUMS, it's IPUMS. Okay, this paper is about young children and parents' labor supply during COVID. And this is a joint work with my colleague at UB, Scott Burkowski, and Inlin Dai at UC San Diego. Okay. So probably I don't have to remind you guys about what happened during the pandemic. Early on, we experienced this massive historic closing of schools and daycare. More than 50 million children saw their schools close. This happened within a very short period of time, 7 to 10 days, massive historic closing, and something similar happened to daycare as well. By early April, majority of daycare was closed, and even the ones that remained open, they were operating at less than 50% capacity. So what does that mean for economists, for who study childcare? So there's this long literature about increasing childcare costs. So school closure means increasing childcare costs. This will lead to parents substituting their own time to care for children. So we were expecting to have lower labor force participation. So for this reason, in early literature that was being circulated right after the school closure, they were predicting that the school closure during COVID would have severe negative impact on labor force participation, especially for mothers. But we think that this prediction is a little less clear during COVID because of the complexity surrounding COVID. Stay-at-home policies and business closures, in fact, may have increased availability of family or neighbors to provide childcare. We understand that social distancing would have mitigated that availability, but more importantly, employers implemented remote work policies and adopted technologies like Zoom that may have allowed parents to continue to work. So we argue that this boils down to an empirical question. So in this paper, we are asking this question: how did school closure during COVID affect the labor supply of parents with young children? So the main challenge in answering this question is that we have to come up with a research design that disentangles the labor demand shock from this school closure effect. Descriptive statistics that was released after COVID, we saw huge, much larger unemployment rate for women. But we also have to keep in mind that women's employment is concentrated around service and hospitality. So our goal is to separate that demand shock from school closure shock. Okay, so that's the key. So what we do in our paper is we follow our publicly pre-specified analysis plan that we submitted before the data was released. So in our pre-specified analysis plan, we have the data and we have the research design all submitted. And then when the data was released, we used a monthly CPS survey from January 2018 through April 2022. We restricted our sample to prime age workers, roughly ages 21 to 59, downloaded from IPUMS. The outcomes that we focus on being at work and hours work, conditional on working, and I will talk more about why we are focusing on those outcomes. And we also use new COVID questions that were added to CPS to provide some insight into how the remote work opportunities have helped parents. And we use additional 2 COVID questions to add credibility to our research design. So the research design that we use 3 variations of event study framework. In our first research design, our treatment group are the ones with young children, and control group are the ones without young children. In our second research design, conditional on being parent, we're only looking at parents. Our treatment group are the ones without a teenager in the house, and the control group are the ones with teenager in the house. The idea is that teenagers age 13 and 21 will help parents taking care of children. So it's like the idea is older kids taking care of younger kids, okay? So in our third research design, similar idea, we are using parents without a grandparent in the household as our treatment group, and we are comparing them to those with a grandparent, being parent and without having a teenager in the house. So those are the 3 research designs that we specify. Preview of our main findings, we found no evidence of negative effect on parents' labor supply. And this, we don't find any systematically different result between men and women. But some of our estimates suggest that mothers actually work more during COVID, which is consistent with this theory that they had to make up for the lost productivity by working longer hours. And new COVID questions, some people find this more interesting, suggest that being able to work remotely help parents, avoiding lowering labor supply. Caveats, okay? Our findings are limited to parents' ability to work. We are not making any claim about parents' welfare. Personally, we know everyone, like every parent was very difficult during this time, taking care of children and working. Right? However, some strength of our analysis is that our design was pre-specified. As you saw, our treatment and control group are different. So there's no data mining here. We specified our research design, the sample and everything. Our design avoids using endogenous policies that's correlated with the COVID infection rate at the geographical region because the COVID infection rate affected business closures, some policies. So we are not relying on those policies because they're endogenous. The other strength is that we are not using the school closure policy because as you saw in the first slide, the school closure happened very rapidly within 7 to 10 days. So there is not much variation that we could rely on to study the effect of school closure. To be transparent, I'm going to talk about the weaknesses too, but as much as we could, these are the weaknesses that we thought about and we are addressing them through robustness check. So first is tied to the lower response rate. Like during COVID, you guys know, I'm preaching to the choir. The response rate was lower. And the concern here is that if that lower in response rate is somehow correlated with the way we define our treatment and control group, our estimate is biased. So we do address that to a certain extent in our robustness check, and I'll talk more about that. And BLS suspects some misclassification that occurred in categorizing people as either employed or unemployed. For that reason, I think focusing on being at work is more clean because the misclassification is less of a problem in that outcome. And as I mentioned, our treatment and control group are not randomly chosen. We get that. They're different by construction. So if you're just looking at the descriptive statistics, they're very different. So what does that mean to us? I think it's very important that we try to control for all observable characteristics as much as we could. And I'm going to talk about that in robustness check. Some results, the fun part. So this is not our main result, but this graph will help us to understand what we are doing. So we have 3 different research designs, and for each research design, we have treatment and control group, right? So we are looking at the difference between treatment and control group, and that's what I'm going to show you. So vertical line measures, the dashed line is between, it's roughly March 2020, and the solid line is April 2020. One thing to note is that even though our treatment and control group are very different by construction, there's parallel trend of some assumption, and I'm going to put some confidence interval in the next slide. So that's kind of the key takeaway message, that we are seeing the difference. So just because we find no evidence, that does not mean that parents did not experience that dip in the employment. Okay. Here's our main result. We are plotting the difference between treatment and control group for each research design. We find no evidence of less likely to be at work, and the result is not different between men and women. If there's anything, we see, I don't know, we see like little bit of more employment for parents, but it kind of fades away. But overall, we don't find any evidence. How about working hours? Here's the estimate that I was talking about a little bit under research design 1. Those estimates are statistically significant, but I think that's also kind of consistent with the idea that mothers made up for lost productivity by working longer. That's the estimate that I was talking about. Some robustness checks. So some of you might be wondering, oh, maybe our treatment group, the parents are in different occupation. Yes, so to address the concern, we have models that includes industry and occupation fixed effects. And maybe 3-year-olds are more difficult to take care of than 9-year-olds. So we do have models, including fixed effects for youngest child's age, all very robust, whether we use sampling weights or not. To address that lower response rate, what we did is we restricted, in one of the specifications, we restricted our samples to 3rd, 4th, 7th, and 8th monthing sample, because 1st, 2nd, 5th, and 6th monthing sample experience even higher response, lower response rate. Okay, yeah. The other thing we did is we did a lot of heterogeneity tests, very similar, except single women were hurt a little bit, which makes sense. So let's get to the COVID question results. These are the 3 questions that we used. The first one is about telework, and the second one is about unable to work, and the third one is about, so third one, keep in mind that this is kind of a different sample than our main analysis sample, because these questions were asked to people who are already out of labor force. So this is a result. This is our telework result. So in research design 2 and 3, well, first of all, you're not going to see those green bars because these are the questions that are added after COVID, May 2020. So there's no pre-period. So that's why this is suggestive evidence. So we are being careful here, but parents under research design 2 and 3, it seems like parents telework more. And we see some of that for fathers too, but that kind of fades away. That's our telework result. How about unable to work? This question kind of gets at, adds credibility to our result because this is asking directly, explicitly asking about the labor demand, okay? So we don't find any evidence, systematic difference between treatment and control group here. So we don't think that our result is driven by changes in labor demand condition. And this is, let me remind you, this is a different sample, but we don't really see a lot of the difference between treatment and control group here either, except maybe males who are already out of the labor force kind of said because of childcare they can find work. But what's kind of interesting is we don't see any of that for mothers. To conclude, we find no evidence that parents had to reduce their labor supply because of school closure. Okay, we find suggestive evidence that being able to work remotely played a role in helping parents continue working. So our results show the importance of workers' attachment to their jobs and remote working opportunities, helping parents adjust that big shock that we experienced during COVID. Thank you.
Okay, our last speaker here is Gilbert Gonzales. He's an assistant professor in the Department of Health Policy at Vanderbilt University. His research examines how public policies affect health outcomes, access to care, and health disparities for lesbian, gay, bisexual, and transgender LGBT populations. He's also a graduate of the PhD program in health policy in the University of Minnesota School of Public Health. Welcome back, I guess.
Well, good morning. It's always nice to come back home to the University of Minnesota. I finished here in 2015 and have been at Vanderbilt. And it's nice to be back with family and friends from the Minnesota Pop Center. And I would also, and here today, I'm here to celebrate IPUMS NHIS. Which has just been an incredible data source for my career. And I would also add that I think it was in 2012, the Minnesota Pop Center hosted the RDC conference, perhaps around 2012, 2013. I see some heads going up and down. And I had the opportunity to meet Gary Gates, a demographer who was studying how to measure same-sex couples in census data. And it was because of that singular experience, my dissertation then focused on health insurance coverage for same-sex couples in the United States. And I will always forever be grateful for that conference that the Pop Center hosted. Today, I'm going to talk about marriage and health among sexual minorities in the United States. And just a little bit about me. I'm a health services researcher, health policy researcher, and I've been using secondary data sources, including IPUMS NHIS, to study LGBTQ health and access to care. And here are just some examples of the research that I've done in the past. This one here with Carrie Henning-Smith that was published in JAMA Internal Medicine on comparing health and health risk factors between lesbian, gay, and bisexual adults to their straight peers. This was the first time that the National Health Interview Survey in its 60-something years added sexual orientation to its survey. This is one of our country's leading national health surveys that we use to document the health access to care of the US population. And we were one of the first to download IPUMS NHIS and publish this in 2015. And I think now this paper, last time I checked, I think it has about 400 citations and is one of the first studies to provide baseline estimates for sexual minorities, baseline health disparity estimates for sexual minorities. And we've done some other work looking at access to care and cancers and diabetes and a whole host of factors. But the other thing I'm really proud of is having the opportunity at Vanderbilt to train graduate students, medical students, and even undergrads on how to use IPUMS data for health services research. And these are just a few students who have helped either co-lead or lead the way with their studies. I'll just point out a few that I'm really proud of. One is in the top right. Kyle Gavlik helped me study how the Orlando gun shooting at Pulse, a gay nightclub in Orlando, Florida, how did that affect sexual minority health before and after? And what we found is that immediately after the Orlando Pulse nightclub shooting, we saw sexual minority men reporting worse mental health, including moderate to psychological distress immediately after the Orlando Pulse nightclub shooting. And more recently in health affairs, a PhD student, Nathaniel Tran, and I, and another postdoc, we recently studied high deductible health plans by sexual orientation. And what we learned is that high deductible health plans, yes, create barriers, financial barriers to care, but those disparities tend to be wider for gay, lesbian, and bisexual adults. But you can see where others have published, including in PRPR, Population Research and Policy Review, on some differences in health outcomes between millennials and Generation X when they were at the same age. And what we found is that at the same age, millennials had worse health, they were more likely to be obese, have worse mental health compared to Gen Xers at the same age. So today I want to talk about a new study that I'm working on. This is very preliminary, and I would love any feedback or any ideas you may have on this project using data from IPUMS NHIS. And so the research question today is to describe individual level characteristics on which sexual minorities are getting legally married after the legalization of marriage equality in the United States. And then what is the association between health and marital status or marriage by sexual orientation. We do know that married people tend to live longer, happier, healthier lives. It's not always equal for men and women. Men tend to benefit more from marriage when their female spouse provides assistance in making doctor's appointments or monitoring health behaviors in the household. And so I think this is a new opportunity for us to explore marriage and its relationship to health for sexual minorities, because we've seen recent policy changes that have allowed gay, lesbian, and bisexual adults and other queer populations to marry people of the same sex. And these were because of major victories in the 2010s when Obergefell v. Hodges legalized marriage equality in every state. So here's the rollout of same-sex marriage laws in the United States. Massachusetts was the first state to legalize same-sex marriage in 2004. You can see more states trickle in either by state level Supreme Court decisions or state legislatures legalizing marriage equality. And then there were two major Supreme Court cases. The first one was US v. Windsor, which ruled Section 3 of the Federal Defense of Marriage Act unconstitutional. This meant that the federal government could not define marriage between one man and one woman. And then and immediately after that decision, you can see more states beginning to legalize marriage equality following their state Supreme Courts or legislative action. And then in 2015, in Obergefell v. Hodges, this Supreme Court case mandated that the remaining 13 states were required to legalize marriage equality. And you can see which states those are: Georgia, Kentucky. These are your typical culprits that you would imagine. I live in one of them, Tennessee, Texas, but you can see the list here. And for those, I know there's some microeconomists in the room and people who are using quasi-experimental designs, and you see this and you're like, oh my gosh, this is a perfect opportunity for a diff. And I'm not going to look at Bacon because he's going to say you're going to have issues with this. And I know, Bacon, we can talk later about this. But it's an opportunity to explore the impact between same-sex marriage laws and their effects on health and access to care for LGBTQ populations. And this slide, I think, summarizes what we've learned about the rollout of marriage equality and population level health and access to care for LGBTQ people. And so in California, when they legalized marriage equality in 2008, they found less psychological distress for married adults following the enactment of marriage equality in California. In a study in Massachusetts, at the Fenway Health Center, they noticed that there were fewer mental health care visits among sexual minority men. In a study I did here at the University of Minnesota while I was a PhD student, we used data from the ACS, the American Community Survey, to document health insurance gains in New York. And when we did some follow-up analyses, we found that these were bigger. There were bigger gains for men and same-sex couples compared to women and same-sex couples. And in a more recent study using data from the CDC's Behavioral Risk Factor Surveillance System, we found that same-sex marriage laws increased health insurance coverage and led to better access to care for men in same-sex households. And overall, I think that the research it's pretty evident that healthcare access is improving following marriage equality, but I'm finding mixed evidence, and I'm not quite confident in the mental health improvements following the law changes, and also not really even effects for men and women. So during lunch, if you have ideas on why men may be benefiting from legal changes in marriage, I would not so much women, I would be happy to talk. But for today, I want to know, and so we're trying to explore who is getting married after these legal changes, when it does become legal, and are sexual minorities getting married following the legalization. For this study, we're using data from IPUMS NHIS. This is the National Health Interview Survey. We've pulled together 10 years of data from 2013 through 2022. And you can see the sample sizes here for adults aged 18 years and older, about 288,000 straight or heterosexual adults. The sample includes about 5,000 lesbian and gay adults and 3,700 bisexual adults. Friendly reminder, always cite your data, always cite the IPUMS data. It's always important for them to track what's getting published and when and where. So I'm just going to provide some descriptive statistics, some logistic regression results predicting whether people are legally married, and some bivariate comparisons of health outcomes by marital status and sexual orientation. So this slide shows the trends in marriage. This is when participants are saying that they are married and legally married between 2013 and 2022. You can see it's pretty flat for heterosexuals. And if you get into the decimals, it is going down a little bit. But what's interesting here is that lesbian and gay adults are more likely to be married after the 2013 US v. Windsor case, and even more so after the 2015 Supreme Court case. In 2013, about 14% of lesbian and gay adults were married, but by within that 10-year period, we see almost a 10 percentage point increase in the likelihood of being married for gay and lesbian adults, sometimes even as high as 29 and 30%. And for bisexuals, it looks pretty flat, but hovering around 23 to 22% of bisexual adults saying that they are married. And again, these are all adults 18 years and older. Here are some odds ratios predicting the likelihood of saying self-reporting that you are married. I'll walk us through this. And so compared to those who are in their 20s, those who are in their 30s, 40s, 50s, 60s are more likely to be married. You can see that there are greater odds in reporting marriage, and it kind of goes down a little bit for those who are 70. This is probably because they're more likely to report that they're separated, divorced, or widowed. At this point, white adults are more likely to be married compared to Hispanic adults. Men are more likely to report being married compared to females. Non-citizens are more likely to report being married than citizens. The other big predictor of reporting being married are for those who are higher incomes. And again, this slide shows heterosexual adults age 18 years and older. And this next slide will show you the same analysis for gay and lesbian adults. And what we see is that similar to their heterosexual peers, older age is a predictor of being married. But when we look at race, there's not really any patterns predicting the likelihood of being married for race when compared to Hispanic adults. Interestingly, females are more likely to report being married than their male peers, which suggests that lesbians are more likely to get married compared to their gay male counterparts. The other big predictors of being married for gay and lesbian adults includes having a child in the household and, again, higher incomes. And this last slide compares the predictors of marriage for bisexual adults. And again, we see similar patterns on being older, having a child in the household, and having higher incomes on being married. And this last few slides just demonstrates the associations and the gradients created by being married. And what you'll see here is that in the black bars, these are the percentages of being uninsured for those who are married. The gold are the percentages of being uninsured for those who are cohabiting with a partner but not legally married. And then those orange bars are for those who are reporting never being married at all in their lives. And what you can see is that being married is a strong predictor of having not being uninsured, because oftentimes you can enroll in your spouse's health plan if you're working, or other ways of enrolling together. This shows the marital status patterns on reporting unmet medical care due to cost. And what we see is that married adults are much less likely to report unmet medical care due to cost. Married adults are less likely to report having no usual source of care, meaning that they do have a primary care provider or a facility that they can go to. It's much lower. And this last slide shows a gradient for those who are married and looking at moderate to severe psychological distress. So heterosexual adults, about 16% of those who are married are reporting moderate to psychological distress. But those who say that they're never married, about 40% of them are reporting moderate to severe psychological distress, just showing some of the benefits of marriage are starting to even play out in some of our data. So just to wrap up, this is very preliminary research. It's now that I'm an associate professor with tenure, I'm trying to do some stretching with exploring marriage and its influence on health. And just to summarize what we're finding here is that about 15% of straight adults 18 years and older are married, about 25% of gay and lesbian adults are married, and 20% of bisexuals are married in the NHIS. Legal marriage has substantially increased among gay and lesbian adults in the past 10 years, but it's not quite at the same levels of their straight peers. And it remains pretty frequent among high-income families. And so we should think about the role of marriage and cohabitation among our lower-income families. Just a quick plug. Lastly, I'm part of the Vanderbilt LGBTQ+ Policy Lab. And we are a host of scholars, including from economics and public health and sociology. And we are always, every year we're hiring a postdoc to come do research with us if they're interested in LGBTQ health or policy. We are also accepting PhD students in various programs. So if you know of any scholars or emerging or budding scholars, please feel free to send them our way. But with that, thank you for having me and happy 30th anniversary.